All right, so I'll just get started. Good morning, everyone. I've met, I think everyone here, but if anyone has not, my name is Jonah Stein. I'm a fourth year medical student visiting from Jefferson. I want to start out just by thanking you all for a great month here. Had a really great experience getting to work with all of you, and it's been a real pleasure. So last week and this week, I've been on sports rotation. So my presentation this morning, I'm going to be talking about medial collateral ligament tear, specifically the Stenner-like lesion. I, of course, have no disclosures. So for the case this morning that I'm going to be talking about is a 15-year-old male, no permanent medical history, came in with 5 days of left knee pain after being tackled during a football game. This is not representative of the patient. He came to an urgent care. He got x-rays taken. MRI was ordered at that time by the PA. He presented at a clinic, to Dr. Buckley's clinic. He was non-weight bearing at the time with crutches and a hinged knee brace on. He was only taking a leave PRN just for pain. No surgical history, no other medical history, no medications, nothing else to report. And review assist was just pretty much negative. As for his exams, we came with his antalgic gait. Inspecting the knee, he had a moderate effusion on the left side. He was pretty diffusely tender to palpation. Otherwise, normal range of motion, normal pulses, normal blood flow to the left lower extremity. As for muscle testing for the patient, he had 3 out of 5 strength in the quad, 3 out of 5 in the hamstrings, and 2 out of 4 patellar reflex. Doing some more specialized exams for the knee. So for stability of the left knee, he had moderate. He was moderate on the valgus stress, 5-10 millimeters. Varus stress minimal, less than 2. Anterior drawer mild. Bachman was positive. He was guarded on the posterior drawer, second of pain, and he had no extensor lag. Here we just see some pre-op imaging done. So his X-rays and AP and lateral. Really no abnormal findings here for the patient's knee. He does have the knee brace on, you see on the right side. Here we had a pre-op MRI done. So just kind of giving the background. So there was a little bit of imaging issues with the software. So only this T1 was able to record as a video. Everything else would just be some screenshots. So here we just see this MRI of our patient. It's a sagittal T1 of left knee. We do see some bone bruising typical of our pathology. We see some discontinuity of the ACL fibers. Here are some screenshots from a sagittal T2 MRI of our patient. On the left side, we see the flat fibers of the ACL compared to the intercondylar roof of the Blumensatz's line. And on the right, we see some bone bruising, like a posterior lateral tibial a little bit, but more so on the lateral femoral condyle, we see some bone bruising. Here's a screenshot from the coronal T2 MRI. We do see the same bone bruising pattern that we saw in the sagittal, a little bit more on the tibial side as apparent. And we see some discontinuity of the MCL fibers seen on the left side of the image, indicative of a MCL tear. In terms of our assessment plan for the patient, so pretty complex injury to the left knee, complete tear of the ACL, distal MCL tear, a lateral meniscus tear. There's also some lateral femoral condyle cartilage defects seen, which I'll show from the op pictures, and then there's some loose body seen in the left knee as well. The plan at the time was to do an ACL reconstruction with quad tendon autograft, MCL repair with internal bracing, and as for repairing the lateral meniscus versus debridement, that was to be decided intraoperatively. So surgery was planned for last week. Dr. Buckley did the case. I met with Dr. Swan. Dr. Silver assisted, and I got to observe and assist when asked. As for the procedure, so we did all the things we talked about before. The ACL reconstruction with a quad tendon autograft. The decision was made to do a quad tendon autograft just because of his open growth plates as well as the concomitant MCL tear. The repair of the lateral meniscus was done as opposed to debridement. There was some repair and fixation of the lateral femoral condyle second to that osteochondral defect. And this was done under general and regional anesthesia. Here we see some pictures on the right of what the internal bracing of the MCL would look like. So kind of during the surgery, just not really going into the full detail of the steps, but in general, we started out with the quad tendon autograft harvesting preparation. Then a diagnostic arthroscopy was performed, looking at all compartments of the knee, starting with the medial compartment, then looking at the ACL. So we saw like the empty wall sign kind of seen here in the top right of the slide. and then our tunnels. Then we looked at the lateral compartment. We saw the defect in the lateral meniscus, and that was repaired at this time. Lateral femoral condyle was visualized more completely. The tibial tunnel was done for the ACL repair. On the bottom right, we see a picture of what this kind of osteochondral defect would look like that we saw on the lateral femoral condyle. It was not that big, but it was significant enough and worthy of being repaired. And then kind of just completing the procedure, we looked at the MCL. It was completely torn distally. It was actually flipped above the pes anserinatus tendon in a stenotype lesion. Anchors and Q-fix was done for MCL repair, like an internal bracing, and then ACL fixation screws were put in, and then the wound was closed. This was a picture that we had from surgery that day. We took a lot more pictures, but this is kind of the only one that kind of came out decently. Otherwise, they were a little bit blurry, but we do see that the repair of the MCL with like the tendon above it. Kind of just briefly going over a approach to the medial knee. So this incision is long, curved incision, 2 centimeters approximately the adductor tubercle, and about 6 centimeters below the joint line. In terms of superficial dissection, you're raising the skin, exposing the fascia, and you're incising to the midline anteriorly and to the posterior medial corner posteriorly. There are kind of two ways of going about the next steps of the procedure, whether you're going anteriorly or posteriorly. In terms of going for the superficial MCL, the anterior was preferred. So incising the sartorial fascia, retracting posteriorly, and retracting the pes muscles posteriorly exposed tibial insertion of the superficial medial ligament is performed. And then just for comparison, this is the posterior approach. And then just briefly looking at the layers of the medial knee. So we have sartorius and the deep fascia in the first layer. And then in between that first and second layer, we're looking at the gracilis and semitendinosus muscles. In the second layer, we have the semimembranosus, the superficial MCL, the posterior oblique ligament, and the MPFL. And then lastly, in the third layer, we have the deep MCL, the capsule, the coronary ligaments. Of note, we should definitely look out for the saphenous vein, which is like in between the sartorius and gracilis in like the first layer of the medial knee. And then there's some important vessels like the medial inferior genicular artery and popliteal artery you can find deeper. In terms of our MCL anatomy, we have the superficial and deep MCLs, which are kind of treated pretty differently. As for the superficial, though, the femoral attachments to the medial epicondyle, 1 centimeter anterior and distal to the adductor tubercle. And for the tibial attachment, proximal tibial periosteum, 4 centimeters distal to the joint line, deep and posterior to the pes anserinatus. And then for the blood supply of the MCL, we have the superior medial and inferior medial genicular arteries, which are branches off the femoral artery. In terms of MCL tears, so it's usually due to a valgus stress. Contact is more common than non-contact, and it tends to be more commonly found at the femoral insertion versus the tibial insertion. As for non-contact, it's most commonly seen with like skiing accidents, usually some sort of pivoting, cutting activity with valgus and external rotation forces. It's usually a low grade or incomplete tear for such a non-contact injury. When it's associated with other injuries, ACL tears tends to be the highest associated ligamentous injury, more commonly seen with a grade 3 MCL versus a grade 2 or grade 1. And it can also be associated with a meniscal tear. Medial is more common than lateral. The basic grading system for an MCL tear is just done based on how much joint laxity is seen. This system was described in 1966, so it's a little bit outdated. The valgus stress is applied to the knee in 30 degrees of flexion, and you're just graded by the amount of medial joint line opening, where anything less than 3 millimeters is considered physiologic. There was a more complicated modification done to the classification, still looking at joint laxity injury severity, but they're also looking at firm endpoints with that joint laxity. The only thing really important to focus on is that you can actually have firm endpoints for grade 1 and grade 2, but that there's no endpoint seen with valgus stress for a grade 3. But this is really used to guide treatment for an isolated MCL. Of course, when it occurs in conjunction with an ACL tear, it becomes a little more complicated. So just a few basic research studies to kind of talk about specifically Stenner-like lesions. So this study was a more radiographic study. It was looking at these two radiologists were looking at MRI exams, 65 knees, 20 cases of grade 3 superficial MCL tears. Of those 20, 12 or 60% were steno-like lesions, and 6 or 30% were considered borderline lesions. Of those 18, 14 were associated with multiligamentous knee injuries, 9 underwent MCL repair reconstruction. So just kind of looking at different other findings during these cases. Another radiographic study, Boutin et al., looked at 51 patients at steno-like lesions that were seen in 20 out of the 51 cases. In these cases, they were more likely to have a medial compartment osseous injury. That was statistically significant. They also looked at something in the radiographic findings. There's this, they called like a wavy contour that they saw, and that tend to occur more distal and more medial with a steno-like lesion versus not. This was just a different study. So it's pretty interesting. They were looking at, they call grade 4 MCL sprains, which of course doesn't fit with the current classification. And they were just suggesting that maybe we need to approach these cases a little differently. So grade 3 doesn't actually account for whether the distal insertion of the MCL is avulsed completely and in front of the pes anserinalis tendons. And potentially we should reform the classification to account for this. But in this study, they looked at just 2 patients. It was a case report. One of the 2 was pretty interesting. It was a 42-year-old female post-skiing accident with a valgus trauma to the knee. They had an MRI, ACL tear was seen, as well as a steno-like lesion in the MCL. And they actually treated this patient with a 2-stage procedure. In the first of the 2, they did arthroscopic resection of the posterior horn of the medial meniscus. They did an exploration of the MCL, followed by ACL reconstruction after full range of motion in the second. So they kind of were treating the 2 injuries separately, as opposed to being a steno-like lesion, where nowadays we tend to lean for a 1-stage, all at once, very acutely treated for both the MCL and the ACL. This was a just different study. They looked at guidelines for how to approach these injuries. They found that outcomes were better if the ACL was reconstructed, and that reconstruction was delayed to allow for return of knee range of motion. So you kind of want the MCL to heal appropriately, and then you can then replace the ACL or reconstruct it. The steno-like lesion of the MCL or subluxation with entrapment should be identified early, which is a key finding here. These should be treated very differently. But of course, there's a lot of debate in the literature. And in fact, the literature itself is pretty sparse to discuss these steno-like lesions of the MCL. So just in conclusion, there's a lot of debate over the management of MCL tears in the setting of concomitant ACL tears. This current grading system that we have does not account for steno-like lesions of the MCL involving the flipping of the superficial MCL over the pes anserine tendons. And there's just a paucity of literature right now discussing the management of these lesions. So it's definitely room for future research in the area. These are my references. Yeah. Exactly. So I think all of the research that I encountered actually just said to definitely treat it, but a question of how do they approach it in a guideline fashion. So especially if it's an isolated stenoid lesion, I mean, if it's not anatomic positioning, so you need to put it back in its spot, which is behind the pes anserine. Right. It's more so that they do, what I saw in the limited research that exists on this, it seems like they do well when you do fix it. No one is doing a retrospective comparison of these, or at least that I saw, comparing whether you fixed it acutely or subacutely, or just waited a little bit longer, and then saying that they got better if you fixed it early. But they did tend to do well if you fixed it. Like I said, the research on these lesions is quite limited. You're saying comparing people with steno-like lesions versus people without steno-like lesions, but both have like a grade 3 or more. I believe they tend to do as well, but I think that the timeline is different. There seems to be a much quicker rush to fixing it. Because like I guess the current thought process is sometimes you want to like let it scar, let it heal, get more stability of the knee, and then you can go back in if you have to fix it later, but usually it'll be okay. But it's unstable. The ligament is not in its appropriate position. And the belief in the literature that I saw was just to rush to treat that as quickly as possible. Yeah, so I think it was like 75%. Right. What's that? So he had a lateral osteochondral defect. This was just in this one study that they did have a medial compartment osseous injury. Yeah, pressure's up. MEPs. Thank you.